Okay, are you seeing my screen?
Yes, Professor.
Great. Okay. So whether we call it myelodysplasia or myelodysplastic syndrome, we'll be talking about the same thing. And most times you'll find people referring it to myelodysplastic syndrome. So that's the term that I will use today. So what I will go through is what is myelodysplastic syndrome, the pathophysiology of the condition, how we classify the myelodysplastic syndromes, the epidemiology, the clinical presentation and differential diagnosis, investigations and staging, treatment and prognosis. So the myelodysplastic syndromes are a heterogeneous group of related clonal hematopoietic disorders and characterized by ineffective hematopoiesis. So what do we mean? We mean that it is a clonal disorder, means that it arises from one cell that mutates, then it gives rise to other cells with that same mutation. This mutation confers some characteristics to this cell. This cell that is mutated is unable to function normally, all right? And therefore, when we say ineffective hematopoiesis, we mean that although the cells are being produced, they are not normally functioning blood cells. And that's what we mean by ineffective hematopoiesis. So the patients present with dysplasia in their hematopoietic cells. And I know you've had some pathology, anatomic pathology lectures, so you know what dysplasia is. It is a cell which has abnormal morphology, abnormal differentiation, and abnormal maturation. So the cells that are produced through this clonal proliferation are dysplastic cells. And therefore, a patient will present with features of bone marrow failure because these dysplastic cells do not function normally. The patients may also present with peripheral cytopenias. Now, why I've written cytopenia or cytopenias, you may find it is only the red cell or primarily the red cell line that is affected, or the granulocytic line, or the platelets or the megakaryocytic line, okay? Any one of those lines may be affected and to any degree, so that you may have a monocytopenia, a bicytopenia, or even a pancytopenia of blood. The other thing about these disorders is that there's a risk of progression to acute myeloid leukemia. Therefore, they are pre-malignant, okay? And actually, it is a neoplastic condition in that there's this proliferation, which is not under any control or the normal control mechanisms that regulate hematopoiesis. So it is a pre-malignant and it is also a neoplastic condition. The bone marrow is usually hypercellular. So this is in contrast to aplastic anemia. In aplastic anemia, your cells, your marrow precursors are normal, but they're very few. But in this one, the bone marrow is hypercellular with these dysplastic cells. The cells have abnormal morphology, they differentiate abnormally, and the maturation is also abnormal. And therefore, that's why we said there is ineffective hematopoiesis or ineffective blood cell production. So that is what the myelodysplastic syndromes or myelodysplasia is in a nutshell. And we're now going to go on further to break down or to open up these aspects and look at them in more detail. Oops. I don't know why can you, oops, sorry, that's moved too fast. It's not moving. Okay, oops. Okay. Can you still hear me? If you don't hear me, if my internet goes out, please alert me so that I'm aware. I won't be able to see chat boxes, but the class rep had my number and she could call me or send me a message. Okay.
Yes, Professor, we can hear you.
Good.
Okay.
All right, that's fine. Okay, so how does this myelodysplastic syndromes come about? As I mentioned, there's a mutation in the stem cell, which leads to an abnormal clone predominating in the bone marrow. So this abnormal clone suppresses the normal healthy stem cells. It overcomes them so that the normal healthy stem cells are slowly replaced by this abnormal clone, which has some proliferative advantage. And this mutation may result from genetic predisposition. That means that there are some individuals who, through their genes, are predisposed to developing myelodysplastic syndrome. And you may find such individuals have in their family, maybe they have a family member who has cancer, another family member had breast cancer, had prostatic cancer, had blood cell cancer, and this other one now has myelodysplasia. So there are some people who have genetic predisposition. Or the second could be due to hematopoietic stem cell injury caused by exposure to any of the following. So anybody who has had cytotoxic chemotherapy, and here we recall maybe if a patient had, say, let's say they had Hodgkin's lymphoma, they were treated by cytotoxics, and then several years later, present with myelodysplasia. This is because cytotoxics can predispose one to developing myelodysplasia. If one had radiation therapy, again, mostly can be due to treatment, but again, could be due to areas where you've had radiation accidents or some areas where there is high natural radiation. Some viral infections can predispose one to myelodysplastic syndrome, especially where there is subsequent immune disease. And then some genotoxic chemicals, some chemicals like benzene, some of the agricultural chemicals that are used, like organophosphoruses, have also been implicated. So there are several chemicals or injuries that can cause the stem cell to become mutated and then give rise to this abnormal clone. So if you look at the diagram, it shows you the stem cell, and then there's a mutagenic effect, which causes a clonal expansion of these mutated stem cells. These mutated stem cells will also be seen in circulation in the peripheral blood, but they will also crowd out the normal stem cells in the bone marrow. And because these cells do not function normally, we have a state known as ineffective hemopoiesis, where there is proliferation of cells, but they're not giving rise to normal blood cells. And we do know that this clonal hemopoiesis, as it is called, these mutated stem cells, can also predispose patients to not only hematologic malignancies, but also to conditions like atherosclerosis, which is accelerated, thrombosis, and heart failure. So there's a lot more coming out now in literature where we do know that something that looks like it might be only affecting the hematologic system actually has effects on other body organ systems. or body functions. Right. So now let us look at how MDS is classified. And I know typically many people hate the classification and they look at it sometimes as if like the lymphoma classification. I'm sure you're aware of your WHO lymphoma classification or the real classification and all those subgroups. However, MDS classification has been evolving. And each time the specific working groups or specialized committees look at it, they're always refining it, adding more groups, splitting it further. And all this aims at identifying characteristic subgroups which have specific specific prognostic characteristics, and also where the treatment can be modified in a certain way. Now, we can broadly classify the MDS into two. There's the primary or idiopathic myelodysplastic syndrome, again also known as de novo. This occurs in approximately 80% of patients who have MDS. And in these patients, we cannot identify any obvious exposure or cause for the MDS. So I mentioned in my previous slide that maybe viruses, chemicals, chemotherapy, etc. But in the primary type, you cannot identify. This is a person who has no obvious predisposition, comes with MDS. Then the secondary, those are the ones where we are able to predict they have had aggressive treatment of other cancers or exposure to radiation, anti-cancer drugs, especially here are alkylating agents or topoisomerase 2 inhibitors. Those are two classes of anti-cancer drugs. And it has been seen with the alkylating agents, patients who've had treatment with that, and these are agents that are very commonly used in many cancers, that these patients have a high risk of developing MDS or secondary acute leukemia about 5 to 7 years after the exposure to the drug. So you can see it is a long-term side effect of the anti-cancer treatment. However, with the topoisomerase 2 inhibitors, that transformation is even shorter, 1 to 3 years. And indeed, in the wards, we have met patients who had been treated for cancer, then they come back, they're sickly again. And when we investigate them, we find that now they have the myelodysplastic syndrome. The development of additional mutations, and as you know, when a cell mutates, it is also liable to get additional mutations. The development of additional mutations may result in the transformation of MDS to acute myeloid leukemia. So that is one thing about MDS. The risk to transform to acute myeloid leukemia is there. Again, it will depend upon the exact subgroup or type of MDS that is present. So that is a very broad classification. I think that one is not too hard for you to know. Before we go to the more complex one, which you'll be forgiven if you don't remember everything, but if you have an idea of how the more complex classification goes. Now, this is the 2016 WHO classification, which was devolved or which was modified from the 2008 WHO classification. And in this classification, cytopenia or cytopenias are a major criterion. So MDS, we say, will always present with either one cytopenia or 2 or 3. So the hemoglobin will be low, less than 10 grams per deciliter in an adult. The absolute neutrophil count. Now look, I'm not talking about the percentage of neutrophils, but I'm talking about the absolute count, the actual neutrophil count. The normal we say is above 2, but in this one, in MDS, it falls to less than 1.8 times 10 to the 9 per liter. The platelet count also falls to less than 100 times 10 to the 9 per liter. And as I've said, the MDS may involve 1, 2, or all 3 myeloid cell lineages, erythrocytic, granulocytic, or megakaryocytic, and therefore may present with either a monocytopenia, such as isolated anemia or isolated neutropenia, or isolated thrombocytopenia. It may be a bicytopenia, where you may have anemia and neutropenia, or anemia, thrombocytopenia, or any combination, or it can be a pancytopenia where all will be reduced. Now, the MDS classification of the WHO 2016 also considers the blast cell proportion in the blood and bone marrow, so that all the myeloid cell lineages that show dysplastic changes, so it will consider, are there blasts present, and what is there an increase in blast, and what is the count of the blasts? It will look at which myeloid cell lineages show dysplastic changes. Although we said a stem cell is affected, 1 or 2 or 3 of the cell lineages may be much more affected than the others. So we look at which cell lineages are affected by dysplastic changes. We also consider whether there are ring sideroblast erythroid precursors. And I will tell you later, you may have forgotten from your previous classes, what a ring sideroblast is. This is an abnormal erythroid precursor, and I will tell you more about it as we go on. The classification will also consider whether our rods are present or not. And if you remember, our rods were seen in acute myeloid leukemia, but we can also see them in the myelodysplastic syndromes. And then we also very importantly consider, and this was not considered in the earlier classifications, were cytogenetic findings. So cytogenetic findings have now emerged as being quite important in certain groups of the myelodysplastic syndromes, and they confer some diagnostic and also prognostic significance to the disorder. And the degree to which the cell lineages are affected, okay? Are they severely affected? Are you having a severe anemia, a severe neutropenia? Or is it a mild degree? So that degree of affectation and the types of cytogenetic abnormalities will impact on the prognosis of the patient. So there are some classes of MDS which will tend to have a very good prognosis with a longer expected lifespan, whether treated or not. And then there are others which have a dismal prognosis where, when diagnosed, expected lifespan may be just a few months. And some of those with the dismal prognosis have some of the higher rates of transformation to acute myeloid leukemia. Okay, so this is what the classification of MDS is based on. Again, this is fairly simple to remember or to have some idea. And then we look at the different classes. I have now simplified this very easily. I won't expect you really to remember each one of them in detail. This is just to show you that the classification involves many different classes. In the very early days, there were only about 4 classes, but as findings have evolved, more classes are being found and more is going to be seen. Now, we mentioned that it can be MDS with only one peripheral blood are less than 1%. You know that normally we should not be seeing any blasts in circulation. In the normal individual, we should not see blasts in circulation, but in MDS, we do tend to see blasts in circulation, but in this category, they are less than 1%, and even in the bone marrow, they are less than 5%. So in the bone marrow, those are normal numbers of blasts. However, you will see those dysplastic changes. So those are standard. Dysplastic changes will be standard. Then we have that with ringed sideroblasts. That's a special group where you have ringed sideroblasts in the bone marrow, okay? Again, blasts in peripheral blood and bone marrow are not many. Then you have MDS with multilineage dysplasia. This is more than one cell line is involved. It can either be 2 cell lines or 3 cell lines. Again, blasts are not many and no hour rods are seen. Then we have the next group where there now is MDS with excess blasts. Now I have lumped several groups of subgroups of this together, but just to let you know that when they have excess blasts in the bone marrow, you're seeing 5 to 19% of blasts. Now that is way above normal. When you hit 20% blasts, if you remember, that now becomes your diagnosis of acute leukemia. In this case, there may be or may not be hour rods present, okay? Again, you have more blasts in the peripheral blood of 2 to 19%. Then a special category of MDS, this one used to be considered with a single lineage dysplasia, but was teased out because this one has better prognosis and has a specific cytogenetic abnormality, which is the deletion of the long arm of chromosome 5. Then there are other myelodysplastic syndromes, and up to now, we have not found anything that can characterize them. So they're all piled under unclassifiable, all right? And then in these ones, they have blasts, peripheral blood film blasts of 1%, bone marrow less than 5. There may be or may not be hour rods, but these ones now do not fall into the other groups we mentioned. And then there's a special category of childhood myelodysplastic syndrome, okay? So those are the simplified WHO revision. If you open your WHO text and you look at it, you'll see very many subdivisions of these, but these are the groups. But this is just to give you an idea of the complexity of the myelodysplastic syndromes. I won't expect you to remember each one in detail, but to know that we classify them based on whether it's a single cell line dysplasia or not, the number of blasts in circulation, and those in the bone marrow, and also the cytogenetic abnormalities. Now, the cytogenetic abnormalities, we can look at them as in 3 groups. There are those MDS who have a normal karyotype. There will be those where there is a chromosomal abnormality, that is a balanced chromosomal abnormality, causing the generation of fusion oncogenes. This is very similar to what you saw in chronic myeloid leukemia, where you have a balanced chromosomal translocation. And then there are those where there are very complex, where there are more than 3 abnormalities. Sometimes we're not even able to identify all the abnormalities that have happened. And we do see these complex karyotypes in about 30% of primary myelodysplastic cases, and more in the therapy-related myelodysplastic cases and acute myeloid leukemia cases. And as you can imagine, these complex karyotypes confer a worse prognosis for the patient. Some of the recurrent aberrations or abnormalities, by recurrent aberrations, that means that these are chromosome abnormalities that we continuously or frequently see in myelodysplastic syndromes, such as missing chromosome 5, deletion of the long arm of chromosome 5, a missing chromosome 7, deletion of the long arm of chromosome 7, an additional chromosome 8, and several others. And we postulate, or it is postulated, that the genes that are affected in these abnormalities have a role in the pathogenesis of MDS. And these genes either may function as giving you, or the genes that are involved may be due to loss of tumor suppressor genes. So for example, loss of part of chromosome 5 or a whole chromosome 5, you may be losing a tumor suppressor gene in that material that is lost. Or there is haploinsufficiency of genes. That means that you have lost a gene and the gene that remains is insufficient to prevent cancer development. It's not sufficient for normal myelopoiesis to occur, all right? So those are, that's a snapshot in the cytogenetic abnormalities. Although we're not able to do cytogenetic testing in our institution, we do know, however, that cytogenetic testing for these types of diseases is critical, not only in prognostication, but also for diagnosis. And we will see why it's important for diagnosis to be able to do cytogenetic testing. So let's look at the epidemiology of the condition. MDS is found worldwide. So there is no part of the world where it is not there. We do have limited local data. Not much in our setting has been published about the incidence of MDS. However, we do know it is seen, especially more in elderly people. And this is because the disease primarily affects elderly people. And if you remember your lectures on oncogenesis, we know that as somebody ages, your cellular DNA repair mechanisms, your apoptotic mechanisms, etc., begin to fail, and therefore getting genetic aberrations as you age becomes more common than in a younger person. The median onset is the 7th decade of life. And the National Cancer Institute in the US reports that 86% of MDS cases were diagnosed in patients or individuals over 60 years or older, and that the median age of diagnosis was 76 years. And therefore, we now in our country, because we are having people having a longer lifespan, we are now seeing more and more people presenting with MDS, as opposed to maybe 50 years ago, when the lifespan was much shorter and people did not live long enough to present with MDS. So the increasing incidence is largely due to an increase in elderly population, as well as where there's improved knowledge and better diagnostic acumen or awareness on the disorder, because it is very much a disorder of exclusion, because making the diagnosis of MDS may not be as simple as it seems. okay? And then across all ages, we do see that males are affected by MDS more than females. And the ratio is about 1.8 to 1. So males, in most literature, you'll see are affected more by MDS than females. So what is the presentation of a patient who has MDS? How do they present? Now, it is insidious in onset. That means that people start getting ill rather slowly in most cases, unless it is one where there are the multiple abnormalities where they may have a more rapid onset. And the patient may present with an unexplained macrocytic anemia. So unexplained means they come with a macrocytic anemia, the HB is low, MCV is high, but when you do your vitamin B12, you do your folate, you look for things like alcoholism, thyroid, anything that can cause macrocytosis, you can't find any evidence. Okay, they have no evidence of megaloblastic anemia or other cause of macrocytosis. They may present with a mild thrombocytopenia, and often or many times this thrombocytopenia might be attributed to other conditions like, say, ITP or something like that. Or they may also have a neutropenia. Okay, so this means that in order to diagnose your myelodysplastic syndrome, you have to be very aware. Don't just let a patient go because, oh, we did B12 and folate and they're normal. This patient with macrocytic anemia, nothing wrong, go home. No, there's something wrong, continue investigating them. The anemia will present with the signs and symptoms of anemia. Again, the degree will depend upon how severe the anemia is. And remember, the anemia may be mild if it is one of the less, the less severe myelodysplastic syndromes, or it may be severe anemia, especially the ones with multiple abnormalities or multiple chromosomal abnormalities. They may even present with congestive cardiac failure. The bleeding tendency, like petechiae, ecchymosis, nose, gum bleeding, hemoptysis, hematuria, blood in stools, all those will occur if there's thrombocytopenia, again, depending on the levels of the platelet counts. Neutropenia may manifest as a bacterial, a viral, or fungal infection. Patients often will have a fever. They have a urinary tract infection. And therefore, whenever a patient presents with these features, because sometimes you may think, oh yes, they have anemia, so they have infection, maybe that's the cause. You should still work up patients until you're satisfied you have gotten to the bottom of the cause of the features that you're seeing. So the workup includes complete blood count, differential, peripheral smear, and bone marrow studies. Okay. And this is just to show you, this is an elderly lady, Caucasian. I showed you a Caucasian so that it's easy to show the abnormalities, but sorry, it's an elderly man. He's got some beards. And you can see that he has bleeding. These are ecchymotic spots around the chin. And if you look at the mouth, there were purpuric spots as well around the mouth. And there may be gum bleeding as well. So easy bruising is a common feature, especially where you have the platelets affected. There's the pallor, which goes with the anemia, and the other clinical features of congestive cardiac failure. There may be tachycardia, fevers, and then the other infections may be found. And in some cases, there may be a splenomegaly present. Usually in myelodysplastic syndrome, we don't have a very large spleen. In the older classification, which included chronic myelomonocytic leukemia, CMML, then the spleen would be quite enlarged. But that condition has now been moved out of this newer classification, and it is included in another classification. So if you look at an older book, you're going to see CMML, but that is an older classification. So when you find a patient presenting with those cytopenias, what must you consider? HIV infection. HIV infection can give you any of those cytopenias, and therefore you need to do the test for HIV to exclude that whatever is occurring is because of HIV infection. Deficiencies of vitamin B12, folate, or copper. Again, you find a patient with macrocytosis. We need to do that to exclude that. Exclude aplastic anemia. Again, a bone marrow would be useful because aplastic anemia may present with a macrocytosis. Alcohol abuse. Again, alcoholism can give you macrocytic anemia. Medications such as your anti-cancer drugs or some other medications as well can give you macrocytes. Therefore, a careful history to exclude any drugs that may give you macrocytosis. And then there are the congenital syndromes, Fanconi anemia, which is the hereditary aplastic anemia, X-linked sideroblastic anemia. Again, those are conditions that need to be differentiated from myelodysplastic syndrome. So remember, as I told you, it's a disease of exclusion. You want to exclude something treatable because myelodysplastic syndrome, the treatment is continuously evolving. It's not an easy disease to treat. So before you tell somebody, oh, you have myelodysplastic syndrome, you need to exclude other possible causes of myelodysplasia. Okay, so what are the investigations? And these investigations are useful not only for the diagnosis of the condition, but also for staging these patients. So the total blood count and reticulocyte count are the first test that one would be asking for. And you will find that there is a cytopenia. The anemia, if it is there, would be macrocytic with an elevated MCV. There may be thrombocytopenia or neutropenia, and the reticulocyte count tends to be low. That tells you that despite the bone marrow being hyperplastic, the production of normal cells is low. So that even though you have an anemia, your reticulocyte count there's no increase in reticulocytes as would be expected if you have normal marrow function. Okay, so as I said, you have a monocytopenia, bicytopenia, or pancytopenia. Your peripheral blood film, you will see your macrocytes. There may be dimorphic appearances. So you may get macrocytes and also have microcytic hypochromic cells. This is quite common, especially in the anemia, where you have, due to the condition with ringed sideroblasts, myelodysplastic anemia with ringed sideroblasts. You may see the dimorphic appearances. The white cells, they're dysplastic neutrophils, and I will show you a few images of some of the dysplastic neutrophils That just means that the neutrophils in circulation do not look normal. They may be having what we know as a pseudo-Pelga-Hue abnormality or hypersegmentation. And blasts may also be present. Remember, in many of them, we do see blasts in circulation. The bone marrow, hypercellular, there are dysplastic changes in the marrow cell precursors, the blood cell precursors. Certain subtypes of MDS will have increase in the ringed sideroblasts, and there may be increased blast counts, usually in some maybe up to 20%, because when you hit 20%, it becomes leukemia. Again, these changes, the number of blasts, etc., will depend upon the specific subtype of myelodysplastic syndrome. So when we look at the bone marrow, we look for the dysplasia, we look for the numbers of blasts, and then we try and characterize or classify what type of myelodysplastic syndrome is this we're dealing with. And then, as I said, we really do need to have cytogenetic molecular genetic tests, because with this, we're able to confirm our diagnosis. Remember, there are many other conditions that can give you macrocytosis. Therefore, if you find these cytogenetic abnormalities, then you know, yes, this is definitely myelodysplastic syndrome. Okay, and we mentioned some of these when we were talking about the cytogenetics or molecular genetic abnormalities that we do see in myelodysplastic syndrome. So what other tests? Many of these tests, again, are to try and exclude any other treatable causes of myelodysplasia. So for example, you'll do your serum erythropoietin. This should be done before blood transfusion, because that will modify your findings. We should do serum red cell folate, serum B12, iron studies. Again, in some of these myelodysplastic syndromes, we do get an increase in the iron, especially the myelodysplastic syndrome with ringed sideroblasts. In that one, we tend to see an increase in iron. We will be doing our thyroid stimulating hormone as a screening test for any thyroid abnormalities, because we do know hypothyroidism is associated with macrocytosis. LDH, again, that tends to be raised, especially where you have high cell turnover in the bone marrow. And then other organ function tests, again, to check for comorbidity, because we do know that if somebody has myelodysplastic syndrome and they also have renal disease, then they have a much worse prognosis than somebody who does not have that comorbidity. So besides doing our diagnostic tests, which help in prognostication, we must do other tests to exclude other conditions which may be treatable, as opposed to MDS, which even with whatever treatments we have now, the treatments are not, optimal, meaning that getting cure is quite difficult, or literally very difficult. So how do we stage the disease? Now, the staging uses the IPSS revised system, and this is the International Prognostic Scoring System. And this kind of staging is to delineate or to put your patients into those of very, very low risk, low, intermediate, high, and very high risk. Now, the very high risk patients are those who have marked cytopenias, they have many cytogenetic abnormalities, and the disease is progressing rapidly, and they have very high chances of transforming to acute myeloid leukemia. Putting them into this kind of risk is very useful because, as I said, the treatment is not very well, we don't have very good treatments for myelodysplastic syndrome. So that if somebody comes with very low risk disease, you may opt to watch and see and just give them the supportive treatment. Whereas somebody with very high risk disease, you might just want to start treating them as if they were already transformed to acute myeloid leukemia. So that gives you the basis for the staging. Excuse me. So what do we use in this scoring system in order to come with scores which we use to stage? We look at the cytogenetic and molecular abnormalities. So, for example, normal cytogenetics like 46XY or 46XX with no translocations, or the deletion of the long arm of chromosome 5 have good prognosis. Whereas somebody who's missing chromosome 7 or has multiple abnormalities have a poor prognosis. And therefore, when scoring, like for normal, you give a certain score. For poor prognosis, we'll give another score. Bone marrow blast count, is it less than 5? Is it more than 5? Is it between 5 to 10? Is it between 10 to 19? Again, scores are given for that. The hemoglobin level, is it less than 10? How lower than 10? Is it more than 10? Again, that gives you a score. The platelet counts similarly, and the absolute neutrophil counts. So using those parameters, we assign scores to the patient and then come with a certain score. And this score will tell us whether the patient is very low risk, low, intermediate, high, or very high, those 5 risk groups. And again, because that is going to affect the kind of treatments that we're going to give the patient. And I'm not bogging you down with the scoring itself now. Actually, it's fairly simple. There are even automated applications where one can punch in cytogenetic, how many this, and the other, and then the application will tell you what score you have and what risk group your patient has. So for you, just know what we use when we're doing this scoring system. So the treatment. Now, as I said, the mainstay of treatment, or we do not have an excellent treatment. The treatment is not even as good as what we have for, say, for example, acute lymphoblastic leukemia in children, okay? The treatment for MDS is still evolving, and there is no standard of care that you will find anywhere in the world. Most patients, or many patients, will be in treatment trials. So they are not standard, and many are considered experimental. Therefore, the mainstay is supportive therapy. What do I mean? If somebody has a severe anemia, transfuse packed red cells. If they have a thrombocytopenia, give them platelet concentrates. If they have an infection, treat that infection with antibiotics. So that supportive treatment is very critical in these patients. And there is an approach beyond that now, which is based on the IPSS score, the revised score, the patient's age, because if a patient is older or very elderly, you're much less likely to give aggressive therapy as opposed to a patient who may be 50 years of age. The comorbidities, do they have renal? Do they have liver? Again, you know these patients are elderly. Many elderly patients tend to have other comorbidities like diabetes, etc. And therefore, that makes things harder. And then the patient's expectations. There are some patients who will come and tell you, I'm 80 years old, I've had a good life. I'm not expecting you to start bombarding me with all sorts of treatment. Just give me, a good expectancy, treat my pain, treat my anemia, etc. Then there's a young person who says, oh no, I am young, I'm 40 years old, because they still can get myelodysplastic syndromes at times. And I have a family and I want to live life to my fullest. Give me whatever you can offer, okay? So aggressive approaches like stem cell transplant or aggressive chemotherapy would be therefore reserved for those younger patients. The chemotherapy, again, for those who have very good prognosis, we may not bother giving them any chemotherapy, but those where the blast count has started to rise, we may start to give some chemotherapy. Then there are other pharmacologic products. Some of those are related to the anti-growth factors like lenalidomide. We have others, topotecan, 13-cis-retinoic acid, etc. These can be given depending on the subtype and in combination with hemopoietic growth factors like erythropoietin or granulocyte colony stimulating factors, okay? So we are still discovering more and more molecules that seem to have an effect. And that's why I said that treatment is not standard. Many are experimental, trying out different molecules or pharmacologic products to see if we can get better outcomes. So these are the other supportive treatments like hemopoietic growth factors. These may stimulate bone marrow cell production and reduce apoptosis. For example, recombinant erythropoietin. When we give recombinant erythropoietin, we often may need to give iron supplementation as well. Granulocyte colony stimulating factor. That can be given sometimes in patients who have neutropenia, and they're given, and sometimes it seems to stimulate the production of neutrophils so that the neutrophil count can increase. And then if they have iron overload, again, remember, these are patients who may be frequently transfusing. And the minute somebody is on frequent transfusion, there's the problem of iron overload. So we need to prevent or treat that if it has occurred. And there's the deferasirox, that is the oral iron chelator. There are others which are parenteral, but the oral iron chelator is easier to use because it's given orally, and unlike the others which you have to inject subcutaneously and somebody's on the pump overnight for several hours, the oral iron chelator is much easier to handle. So these are other supportive treatments that will be given to patients. And in addition, please don't forget when we talk of oncology care, because this is a neoplastic condition, may transform to AML, all the other psychosocial support, palliative care, etc., should also be brought to play, okay? Because this is a long-term condition, very often without a good outcome. So if we look here, this is just to show you the clinical outcome against the risk category. There's the median survival. up in the upper part of their clinical outcome and their median time to develop acute myeloid leukemia. Those with very low risk, they have a median survival of about 8.8 years, and their likelihood of transformation to acute myeloid leukemia is very low, all right, or not recorded. Okay, so that is very low. So someone with a very low risk category, they're less likely to develop acute myeloid leukemia. Those with a low risk group, survival around about 5 years, about 10 years before they develop acute myeloid leukemia. Intermediate risk group, only 3 years, and again about 3 years before they transform to acute myeloid leukemia. And this is the median time of 25% of them going into acute myeloid leukemia. Then the high risk group, remember I told you they have very few, very low survival. The median here is 1.6, and this is in a good center where they're able to give the good supportive care. In our center, they actually do not survive very long, especially because of lack of having good enough supportive care. And the risk for them transforming to acute myeloid leukemia is 1.4. So you can see that risk categorization is very useful, because then we know what kind of management is key and what we can expect. Even as we are talking to the patients or counseling them, we know what to expect. These are now some diagrams, okay, just to show you. This is our karyotype. These are the chromosomes. This was a female, and you can see by the XX, and she had this 5q deletion. You can see this is chromosome 5, and part of chromosome 5, the long arm of chromosome 5, this is the centromere there at the center, and the long arm is deleted. This is what we would see if we were to do cytogenetic testing in somebody who has the deletion of 5q. Now, this is, we mentioned the pseudo-Pelger-Huey anomaly. This is a patient with MDS. These are neutrophils. These are not normal neutrophils. You can see they look like somebody who's wearing spectacles, okay? So the neutrophil is bilobed and has a very thin chromatin thread connecting the two lobes. So when we see this kind of abnormality, it may indicate that this somebody might have MDS. I mentioned to you ringed sideroblasts. So ring sideroblasts, these are developing red cells. They are nucleated red cells or erythroblasts, which are abnormal in that the mitochondria are loaded with iron, or they have iron in them. And these iron-loaded mitochondria tend to form a ring around the red cell nucleus. If you can see in the diagram on the right, you can see these mitochondria containing iron. They're forming a ring around the nucleus of the developing red cell, or the erythroblast. Now, we need a special stain in order to see these ringed sideroblasts, and the stain is Prussian blue stain, or Pearl's reaction. And on the right, you can see images of a bone marrow, because the bone marrow is where we're going to see these developing red cells. This bone marrow has been stained with Prussian blue stain, and you can see these blue round dots around the nucleus of these developing red cells. So all these are ringed sideroblasts. And when we do see them, we do know that there is, when we see an increase in these, We know this is that category of myelodysplastic anemia, myelodysplastic syndrome with ringed sideroblasts. Okay, so we can summarize MDS as a heterogeneous. We saw there are many subgroups of it, so it's a heterogeneous group of related clonal hematopoietic disorders, and we saw how they were related, and they're characterized by ineffective hematopoiesis with variable predisposition to transform to acute myeloid leukemia. These disorders arise when you have a mutation in your hematopoietic stem cell, and this causes an abnormal clone to develop, and this clone prevails in the bone marrow. It crowds out or suppresses the normal healthy stem cells. And as they suppress these normal healthy stem cells, the more they suppress, the more the patient presents with all those features of the anemia, the neutropenia, and the thrombocytopenia in whatever combinations. MDS is classified either as primary or idiopathic, which is de novo. And the majority, as we saw, over 80% of MDS is primary or idiopathic, or it can be secondary to aggressive chemotherapy, viral infection, chemicals, etc. It is primarily a disease of the elderly, and we said the median onset is in the 7th decade. Patients present with cytopenias in whatever combination, and the clinical features we see are secondary to these cytopenias. The investigations aim at diagnosing the condition, and especially important is excluding other commoner causes of certain disorders that may be present to stage the condition. And the management relies on supportive treatment, and there is an approach based on the IPSS score, which uses the patient's age, comorbidities, and patient expectations. All right, so that's the end of our lecture on myelodysplastic syndrome. I will end the show and stop sharing now so that I can see or I can take any questions that anybody may have. Are there any questions? Any questions? Yes? Okay, I can see something. The differential diagnosis given were what for MDS or macrocytic anemias. Okay, for MDS. Okay, but remember we said that if you find a patient who has macrocytic anemia, very importantly, you want to see, is this megaloblastic anemia or a non-megaloblastic anemia, all right? Now, you will do your B12, you'll do your folate. So if B12 and folate are low, you know that's megaloblastic anemia, you now treat that. But if you do your B12 and folate and you find those are normal, then you need to think what other causes of macrocytosis are there, rule them out before you diagnose MDS. Remember, I said MDS is very much a diagnosis of exclusion, all right? You don't want to diagnose somebody with MDS and then find out, oh, they had hypothyroidism. That's why they had a macrocytic anemia. Or that's why, so it was hypothyroidism. So we said MDS is one of the causes of macrocytosis, but you must exclude other causes of macrocytosis that are more easily treatable, like hypothyroidism, before you make that diagnosis. Does that answer your question, Niharika? Okay, say yes, so that I know we go on. Okay, so Beata asks, is there an equivalent of MDS in the lymphoid lineage? No, we don't have an equivalent. This is one of the myeloproliferative, referring to the myeloid cells. So no, we don't have equivalent of MDS in the lymphoid lineage. It is a myeloid. And that's why this condition, MDS, is considered under the myeloproliferative neoplasms and not the lymphoproliferative neoplasms. Again, the tendency when you develop the acute leukemia, it is acute myeloid leukemia that the patients will develop. Why do the healthy hematopoietic stem cells get suppressed by the abnormal clones? Oh, very good question. Now, the abnormal clones have a proliferative advantage. Now, when the mutation occurs in that first hematopoietic stem cell, this mutation confers some advantages, proliferative advantages to that cell. One, it may prevent that cell from undergoing apoptosis. We know the normal healthy cells undergo apoptosis, but in many cases, these MDS cells do not undergo apoptosis. And so as your healthy cells are dying, these are just proliferating. Again, the healthy cells are under normal control mechanisms. These abnormal cells do not undergo controlled by healthy mechanisms. In a way, it is very similar to what happened in your leukemia. Remember your acute leukemias, if you've had that lecture, the abnormal cell just multiplies and multiplies and crowds out the normal hematopoietic stem cell, okay? So this is because the abnormal clones have a proliferative advantage. So Eugene asks, what's the utility of assessing UTS in MDS lab assessment? Remember, we said that hypothyroidism, if you remember your causes of macrocytic anemia, you want to exclude all causes of macrocytic anemia before you say somebody has myelodysplastic syndrome. Why? And I must emphasize, because myelodysplastic syndrome does not have a good treatment, whereas a condition like hypothyroidism has good treatment, okay? So that's what we are trying to do, Eugene. We're trying to exclude any other cause of a macrocytosis, okay? Remember, MDS is usually a diagnosis of exclusion, all right? Can Fanconi anemia progress to MDS? Yes, it can. Yes, it can, because it's one of those chromosome breakage syndromes, and it can also progress to acute myeloid leukemia. So you're quite right, Jane. Even some of those other breakage syndromes like Bloom syndrome, etc., they're pretty rare, but they can also present with MDS. That can also happen. There's some, paroxysmal nocturnal hemoglobinuria. Again, sometimes it may present, may also go into an MDS and an acute myeloid leukemia. And then is splenomegaly arising because of extra? Okay, not so much of that, but because you may have, if you have an infection, you may get splenomegaly. Sometimes you may have these abnormal clones there, but not so much because of extramedullary hematopoiesis, not too much of that. Again, I mentioned it there because many of these conditions, especially when you have a higher rising blast count, you may get your splenomegaly. However, as I said, the spleen does not tend to be very large because the category of MDS, where you used to have a very large spleen, which was the chronic myelomonocytic leukemia, that now has been moved to another category of the myeloproliferative neoplasms. Ashley, would stem cell transplant be effective in treatment, or would abnormal cells crowd out the new stem cells? Very good question. Whenever we're giving stem cell transplant for neoplastic conditions like your leukemias, your myelodysplastic, what you first need to do before you transplant the stem cells is to kill off all those abnormal cells. All right. How do you get rid of all those abnormal cells? Is we give very heavy chemotherapy. So if somebody had acute myeloid leukemia, acute or acute leukemia, or they had myelodysplastic syndrome, to get rid of those abnormal cells in the bone marrow, you must first give very heavy chemotherapy, what we call the conditioning regimen. This heavy chemotherapy is followed by profound hypoplasia, and then now we give in the stem cells. And then these stem cells, which are normal, can now go and proliferate. If you give stem cells when those abnormal clones are there, they will be just washed away. They will be crowded out within no time, and you will have failed transplantation. That's why stem cell transplant is not as easy as it sounds, okay? It is a fairly complicated procedure. Okay. Anybody else has questions? Okay, so the important thing is to know that there's this entity, myelodysplastic syndrome. It is a neoplastic condition, and that there are several categories related to each other, and that they are associated with ineffective hemopoiesis, in that even though the marrow is hypercellular, the cells produced are not functioning normally. And therefore, these patients will present with the effects of the lack of the cells that are affected. So anemia, thrombocytopenia, or neutropenia. And that these conditions have that variable liability to transform to acute myeloid leukemia. Okay. All right. But very importantly, it's a diagnosis of exclusion. You must make sure that you diagnose it properly. And where we do, you must always, well, I say you must, but we're not able to do cytogenetic testing here, but you would want to do cytogenetic testing, and you must always exclude other causes. If you have a macrocytic anemia, many present with macrocytic anemia, you must exclude other causes of macrocytic anemia, because you don't want to be told you have myelodysplastic syndrome when actually you had hypothyroidism, okay? Or you are having alcoholism or whatever else it is, okay? All right. Distinction between MDS and myeloproliferative disorders, okay? Myeloproliferative, remember under your myeloproliferative disorders, you do have your chronic myeloid leukemia, you have your chronic myelomonocytic leukemia, you have your acute myeloid leukemia. Those are the other myeloproliferative disorders, okay? So MDS is a subgroup of, we usually say myeloproliferative, myelodysplastic as a subgroup. So myelodysplastic is separated from those because each of those other categories, like chronic myeloid leukemia, has its own presentation, which is quite distinct from myelodysplastic syndrome, where myelodysplastic syndrome typically presents with cytopenias. The other myeloproliferative, like the chronic myeloid, is high white cell count. The other myelofibrosis is fibrosis of the bone marrow, etc. Okay, so they're quite different. So if you just have a look at your myeloproliferative, your other myeloproliferative disorders, and see the distinction between them. Okay. Okay, both all are associated with abnormal clones, but just having an abnormal clone is not enough. You have to look at the character of that disease. So usually I said, like, in you and I, in a normal person, if I find a blast in circulation in their peripheral blood film, I'll be very worried. I will ask for other tests. So in normal people, you do not have blasts in circulation. No, normal people do not have less than 5% blast in circulation. You should have no blasts in your peripheral blood. In your bone marrow, we can have up to 5% blasts, because these blasts are what is giving rise to the cells that are maturing and differentiating and forming normal cells. So remember your hemopoietic lecture, don't mix up. So in normal person, in circulation, you should have 0 blasts circulating about. Okay, generally, that's what we say. So if I start seeing 1, 2 blasts, I must exclude something abnormal happening. Okay. Any measures used to prevent development of MDS post-chemotherapeutic treatments? What we say is that when we give chemotherapy, we must make sure that we're giving the correct doses of chemotherapy. We're giving according to regimens that have been proven or shown to work, and at all times minimize giving any unnecessary chemotherapy. And that's why when we are diagnosing a cancer where we will need to give chemotherapy, we must make sure we have given the correct diagnosis. We have not misdiagnosed somebody. But again, there are no other measures, because in order to treat cancer, you need chemotherapy. If you don't use chemotherapy, that cancer will kill you. But if the chemotherapy, unfortunately, the side effects are the predisposition. Not everybody will get myelodysplasia, but there is the predisposition to get myelodysplasia, and another smaller proportion may even go on to develop acute myeloid leukemia. Yes, there's a risk of remutation in stem cell transplant. Yes, that is one of the risks. Why? Because we've been giving this person, even after treatment, we'll be giving them medicine to try and suppress their own marrow from overcoming these new cells. Okay. All right. Anything? Okay. All right. So I can see you're all